Bismillahirrahmanirrahim. Assalamu alaikum and good morning and good afternoon to everyone. Thank you, all of you, for joining us today into this important webinar on mental health as a universal human right. We have organized this webinar in collaboration with Global Consortium of Universities, CUGH. The website's link is given in the comment box as well. As you all know, that mental health is a critical aspect of human well-being, and it is the time that we talk about the mental health issues, especially pertaining to our students in the universities. We are delighted to have a panel of experts with us today to discuss about importance of recognizing and promoting mental health as a fundamental human right. We're going to start by a brief introduction about the panelists in the session number one. We are joined by Professor Dr. Kerry Ellingson. Professor Kerry is Associate Vice President and Emeritus at the University of Utah, and she has immense experience and expertise in the field of mental health, and she has also been the Director of Student Affairs at the Utah, and she has been engaged in the counseling and wellness counseling related services. Currently, we are engaged with her, Kerry in higher education institutes capacity building regarding mental health through a USAID funded project. We're glad to have Kerry on board. Welcome to the panel discussion. Next, we are joined by Nora Fahad. Nora is a clinical psychologist and she's also a doctoral candidate at College of Osteopathic Medicine and at Philadelphia University. Philadelphia Medical Hospital. She's also the founder of NAF's initiative. Nora, we welcome you to the panel today. And last panelist for the first session is Dr. Iram Gul. Dr. Gul is chairperson of the Department of Behavioral Sciences at Fatima Jinnah Women University. Dr. Gul is also the Director of Counseling and Wellness Center. Also, she's the Director of Student Affairs Office and the Medical Center at Fatima Jinnah University. Dr. Iram, we welcome you to this particular webinar right now. So we are also joined by a number of students, and the format of the session is that each presenter is allowed with 15 minutes to talk about their presentation. We'll be collecting the question answers towards the end of each session. So I'm now going to invite Dr. Nora Fahad to kindly talk about your own experience related to mental health, global experiences. Thank you. Over to Nora.
Thank you so much. I appreciated that, Dr. Naz. So let me share my presentation. So I'm not going to add more about what Dr. Naz said, but I will say that I do have a lot of experience with trauma. And I was surprised that I was assigned to do a role of adverse life events and mental health. And this is a really big topic to finish it within a short period of time. So I will do my best. What is adverse life events? Mostly when I say to people, what is adverse life event, they usually turn or they go directly to, are you able to see my presentation?
No. No, Nora, you need to share your screen.
Sure, sorry about that. Okay, go on. Okay, so when I talk to people about what is adverse life events, they usually think about trauma. And what is trauma to them is usually about war or civil rights or something like that. And it's usually is not always that when it comes to clinical work. Adverse life events are a very challenging life experience that impacts one mentally, psychologically, socially, spiritually, neurobiologically, and behaviorally. And what is life events to one person? It could be a different life events impact on another person. So this is kind of a good picture that I found it very interesting to capture what is adverse life events. It could be maltreatment, abuse or neglect from your childhood or adulthood, or violence that can include domestic abuse between your parents or your significant other, adjustment. And that's what I did because I'm doing my dissertation. I work with refugees. Adjustment and going from one country to another is a trauma. It's not the war to them. The war they accepted, but to them is moving from a different cultural background to another cultural background that is totally different when it comes to values and lifestyle. Prejudice, and this is kind of more likely even between races, different colors, white or black, or between nationalities. Some nationality will view other as like under status, and that's a kind of the prejudice is not only prejudice about races or sexism could be a different type, especially when it comes to women, but easy for their profile to be indicated. That's also could be a prejudice. Household or family adversity, and that means either your parents or significant other or one of your child have substance misuse or intergenerational trauma. And this is a lot special in the Middle East, especially in the Asian country when they have a lot of or a long history of war or trauma. Inhumane treatment, that is kind of torturing or imprison some of the family or parents that imprison. Adult responsibility. Guess what? The older we get, the more things we go through a lot of adverse life events. We have a lot of responsibility that we are taking every single day, especially when you are working in a clinical environment. That's something happened to me personally when I have to survive, when I got in one of my patient unit and he was hanging himself. So I have to help him to stay alive. And that's another responsibility on me. But when I left home, I was devastated. Yeah, I saved him, but it's really affected me. And that is life event, adverse life event. People and death, especially when it comes to war or unexpectedness, that could be adverse life events for others. I found this really interesting adverse life events. I know we have the AC, the adverse life events childhood that has been used a lot worldwide. But this one had been created 3 years ago and had like not only for childhood, also for adults. They haven't really found it like they measure the validity of that scale, but it's open for everyone to test it out and translate it. And when you look at it, it's really capture every single aspect when it comes to adverse life events. Because what is adverse life events for me could be totally different to somebody else, even though we share the same thing. But the impact on that adverse life events could be totally different. So what is the relationship between adverse life events and mental health? I can go on and on and on with this forever, for so long, because I believe clinical DSM diagnosis, because it's easy to capture, it's easy to say, but it could be totally different presentation for other people. When I was searching about trauma, there's 600,000 presentation for trauma response. It's a big number, but it's easy for presentation, but it labels to make it easier for other people. So relationship, when it comes to adverse life events, could be depression, anxiety, trauma-related disorder, personality disorder, eating disorder, and that's like mental health. When it comes to medical or physical condition, which is very popular in our collectivistic culture, who doesn't believe in mental health. They believe, oh, we have issue with our digestion or our like stomach because of the stress we have. So people, sometimes we get ulcers and because of the stress. Some people, they have issue when it comes to, we call it the bowel syndrome, like irritable bowel syndrome, which is very common when it comes to people who have a long history of chronic stress, cancer. I did a lot of interviews with people with trauma, and half of them, they have cancer. I didn't believe that cancer come from fears and stress. Violence, family dysfunction. When you have these people, they just happily married, and because of the stress they have in their life and the life events they have been through, there's like family dysfunction between them. Substance and alcohol use, and it's just very common, especially in the male side more than the female side. Sleep issues, people think is normal, but it's not normal. Sleep issue is a component. When I was working with people with Alzheimer's and memory issues, three things that they recommend for each patient, and one of them is sleep. And heart disease, stress and chronic stress and pressure could make you prone to have heart disease. What can we do to help individuals in low or middle income communities with limited resources? So I think some people, they will understand about the adverse life events and its impact on other people or impact the society or the community. But I'm more practical. I hear, I read, but what we can do for that. And that is something that we need to take into account, because if we are really carry the resources from other countries, they might not be applicable for our community, because we need to think about what is there that we can use to build on it. Because adverse life events, you may think it's fine, we can handle it. No, you said this at the beginning, until like 2-3 weeks, 2-3 months, a year, you collapse. You start burning out at work, you start have dysfunctional relationship, you start engaging in very risky behavior. So what we can do with this? Psychoeducation intervention, we have a huge significant impact, especially for the developing country, about stigma and stereotypes. I believe it's everywhere, even with developing countries, they still have some stigma related to mental health. They think they are crazy, or, oh, we don't need this, or we are spending too much money. Oh, we can't talk to a friend. Guess what? It's not always working. So psychoeducation intervention is number one. When you provide that psychoeducation intervention when it comes to adverse life events and make it clear, don't point to the person, oh, because you have this. Try to think about what is the deficit they have in their life and go from down to top to say, okay, let me help you. Let me make you understand how your life has been impacting because of the adverse life events. I myself, I go to therapy, and sometimes I notice how my work is impacting my life after I go. Nobody, I'm expert in trauma. That's like my whole job for 9 years. But because we are so centered in our life, we didn't know. So the psychoeducation is not only telling you what is the impact, it tells you how to understand yourself. It tells you how to understand your behavior. Storytelling. That's something is very interesting, and I can relate to people from Middle East, from like Muslims country. They don't like Western intervention. I'm sorry, they don't like it. Let me tell you my story. Let me tell you this. I've been interviewing 20 people, and they don't give me a damn definition for trauma. They give me stories. So when you hear their stories, I understand how their life impacts. They may not able to agree with me about mental health, but they were able to tell me what's going on in their life. They were able to hear from me when I hear their stories. When it comes to adverse life events, they like to be very connected. So I'm telling you a story, and you tell my story. You tell me your story, so we can be connected. And this is the whole thing about life events. Arrange psychosocial events. When I say, oh, let's go to therapy, so I'm not crazy. I'm not going to therapy. But if we go, let's hang out somewhere at the park. We talk about something that is related to our struggle as a human or our struggle as a woman. They will be able to go. If you invite them for a coffee, they will able to go. So don't say, let's go to group therapy. And that's what I have to arrange for my people from my country. I'm originally from Saudi Arabia. So people, they don't like group, they don't know what is group therapy is. But when I say let's go, I changed the name to something very common to the community. They love it. They talk about mental health. They talk about how they can solve. They relate to each other. They don't feel like they are alone, and they were able to do so. Arrange psychosocial event that is really associated to your community. Don't look for research in different countries and just do it as is, because you are setting yourself up to fail. Use strength-based intervention. Lately, I believe in the last 5-7 years, they start to think about trauma or adverse life events as to use as a strength-based, not a deficit-based. Most people, they don't like to say I have a problem or there's fix me. They don't like that, but it's easy for them to give them intervention to be able to strengthen their skills and be able to come with this. Most of us born, and they are able to process traumatic events, adverse life events. But some people, they don't for different reasons. One of the things that be able to open to it, don't say, okay, I'm going to reduce your PTSD symptoms. No, say, I'm going to help you to strengthen your skills to be able to handle something in the future. And one of them about resilience, self-compassion, all that translated to positive psychology will be able to. Okay, so self-care. You know what? I hate this word, but sometimes I have to use it. Self-care. What is self-care is when you say, I'm done, I need help. When you start to think not only outside of here, but also in here. Some people, they use exercise, weight training, flexibility training to help them to increase. So when you are able to increase your flexibility, your body, when your body is holding you, if it's too much on it because of a lot of stress you are putting inside of you, they may collapse. And I don't know how many of you can relate to this, but I can't relate to this. My body said, no, I'm not doing this anymore. And this is a sign for me that I'm holding too much. Doing exercise 30 minutes every day, you are really helping yourself to improve your strength and be able to hold and regulate the stress you have. Support, build support relationship and connection. That's something I found in the Middle East and the Asian country. I need help. I need my people. I need people that I can connect to and be able to talk to. But as what I found it very challenging. People, when they are talked to, we are on the mindset, oh, we need to fix them. We need to help them. We need to give them advice. No, they want to be heard. They want to listen to them. They don't want to fix. Sometimes we need God's hand to handle things. We can't really do anything. Sometimes we need time. So be a good listener. It may sound easy, but good luck doing this for a long time. It's not an easy job to be a good listener, empathic, supportive of others. Don't make judgment. Don't shut them up when they're trying to talk something out. They want to be heard because they are struggling with the mental health or the stress they have from adverse life events. Seek help when needed. We found in my research, people who seek help, they are more resilient. Don't think people who ask for help, they are weak. They are not weak. The weaker who are the one who's not resilient. So think about that way. Ask for resources available for the community. Don't say, oh, I need to go therapy to help myself. If it's not applicable, there's no access to it, search for something. There's a lot of online free self-help resources that if you Google it, you will find tons of them. Also apps. There are some apps, especially when it comes to self-care and breathing and tracking your negative thoughts or doing some exercise that is helping you to improve your mindfulness skills. There are there. So sometimes we don't have to wait to be struggling for a long time. With our some resources can help us. Doesn't have to be 100%. Could be like 10%. That's one thing they found in my community. Stigma. People, they don't know about self-care. They don't know how to be a good listener. I developed that because I was very tired of how many stories that I've heard about adverse life events in my community. I developed this 3 years ago. It still gives me help, but I'm still going because I have a mission. I need to help people to understand what is adverse life events, what is psychology, what is trauma, what is group therapy, how we can do this. So I've been doing a lot with this because I'm trying, every time I do something, I send a quick questionnaires to my community, to my people saying, what is something you need? What is something is struggling with you? So based on that, we published 2 books about trauma and life events. We published a book about schizophrenia because no one knows what a schizophrenia is and how to deal with it. So don't underestimate what you can do. One person can do a lot. And my initiative is called Nafs. Nafs in Arabic, that means a soul. And you have, like, if you help one person to be able to manage the adverse life events and trauma they have, it's like you help the whole nation. You don't have to help 100 people. You can help one person. And that's a quick, I like this continuum model about healthy to be ill. And what is the intervention once come to healthy? What is the intervention to when you are injured and ill? And the more you go to the red side or the right side, the more you need help. And sometimes when adverse life events happen and we are able to identify it, we can look for the reaction and injured. You don't have to wait. Don't say, oh, I'm okay, because your body's still taking this. And I really recommend the book called The Body Keeps the Scores, where everyone, like, they tells you about how each life events happen in your life. Your body is keeping it. And that's why, for example, I remember I was in Six Flags, which is a theme park in the United States, and it was this crazy thing. And then a couple years later, I was in a car accident. Somebody hit me, and my brain, because of that, my belt, like the safety belt, is like really pressed on my chest. The same as happened when I was in Six Flags having fun. When I have the car accident, my brain goes to the Six Flags that happens a couple years ago. And then within a second, I realized, oh no, I'm in a car accident. That's exactly how your body is holding all experience that you have. If you are not able to recognize it, it's gonna store it here, and it's like a pressure pot. It's gonna be here until you release it. So you don't have to wait until the last thing to, like, the after you found there's, oh my God, my life is growing up now. I need to do something. No, the earlier you do, the better you are saving your life later. Because once you got to that point, for example, God forbid, suicide ideation, you may not help. You may not have immediate help. You may not know exactly what's going on. So adverse life event is very simple, and I think not many people they understand the impact of it, but it's really severe. I've been doing trauma work for 9 years. I'm doing my dissertations in trauma and Muslim Arab refugees, female, and I learned a lot. I learned trauma is not trauma that we know in DSM-5, not at all. I learned resilience. Resilience is about geographical. Resilience in Saudi Arabia is different from Pakistan, is different from United States. When I said family connection, I'm sure like people in Pakistan may relate. Family connection is our family, extended family, the neighbor, could be the whole neighbor, right? That's our family versus people in the Western countries, our family is the immediate family. So I want you to just give a thoughts about the adverse life event that you may have, or your colleagues have, or your family member have, and have a reflection about how those events is kind of impacting them. That is my reference. And thank you so much for listening. I appreciate the opportunity to be in this panel.
Thank you very much, Nora. It was very useful and it was an informative session. Thank you for joining us. If we have any question and answers for Nora, please leave the question answer in the chat box, and I hope you remain connected with us. We now move on to our next speaker, Professor Dr. Kerry. Dr. Kerry is associate, she's emeritus professor at the University of Utah. Over to Kerry.
Okay, so good morning in Utah. Good afternoon, good evening. As Dr. Naz said, I'm Dr. Kerry Ellingston, Associate Vice President Emeritus at the University of Utah. I'm also a psychologist. So what I'm going to be covering is a very, very brief overview of mental health as a human right. And as Dr. Naz says, if you have any questions, please just leave them in the question and answer, and we'll get to them at the end. So this definition, mental health, a state of mental well-being that enables people to cope with the stresses of life, to realize their abilities to learn well and to work well, and to contribute to their communities. Mental health is an integral component of health and well-being and is more than just the absence of a mental disorder. Everyone has a right to mental health. And I really like this definition because it emphasizes not only the impact of mental health on the individual, but also on the community where they work and where they live and where they learn. So I'm involved with Sajida on a project funded by U.S. Agency for International Development, working with the Pakistan Higher Education Commission and 16 universities, and you'll be hearing from several of those universities today. The whole goal of the project is to increase employability of the graduates in Pakistan and their employment opportunities. And what's really interesting is when the project started, mental health was not included. And I think very shortly they realized that if we're talking about producing healthy and employable graduates, ignoring their mental health is not a very wise thing. So why are we discussing mental health? Well, neuropsychiatric disorders account for over 10% of all of the global burden of disease. And as we'll continue to talk about, it's often ignored. 13% of the global population is living with a mental health disorder. And this is one of the lower numbers I've seen. As we all know, statistics can say a lot of different things. 13% seem to be an average. Okay. Depression and anxiety rates increased 25% in the first year of COVID. And while a lot of the data you'll see is pre-COVID, there's not a lot of statistics yet that says this depression and anxiety is decreasing. Okay. Suicides account for 1 in every 100 deaths globally, and there may be 20 attempts for every completion. And suicide is a major leading cause of death for 15 to 29-year-olds, which if we're working at a university, this is our target population. So when you think about it, who estimates that globally A person commits suicide every 45 seconds, which means in the course of this presentation for 3 hours, 240 people will be taking their own life, which is a staggering thought. On average, and I'll talk more about this later, countries spend less than 2% of their healthcare budget on mental health treatment, on mental health. And with treatment for depression and anxiety, it provides a benefit cost ratio of 5-to-1, meaning for every dollar a country invests in treating depression and anxiety, they recoup $5 in decreased healthcare costs, in increased productivity. It's money well spent. And the median of mental health workers globally have 9 mental health care workers per 100,000. And many countries, half of the countries, have 1 psychiatrist per 200,000. And if you look at this graph, you'll see that this very disproportionately impacts low and lower middle income countries. High income countries, not without mental health problems, but the issue is not a lack of mental health workers. I just liked this graph. I'm not going to go into it in detail, but I'm assuming that everybody on this webinar knows the value of mental health. Connection, coping, thriving, functioning. The main point is that mental health is a basic right that allows us to function and thrive in our world. And it should be given the same priority as physical health. This data doesn't include substance abuse, but what I wanted to show you is the pre-COVID, the global prevalence of mental health. 60% of the disorders are anxiety and depression. This also seems to ring true at colleges, at least within the United States. And let's just look at depression, which accounts for, between 1/4 and 1/3 of all of the issues. Well, if we look at the cost of depression, major depression, decreased quality of life, increased missed work days and decreased work performance, higher risk of coronary disease, diabetes, Parkinson's, not only the higher risk of developing this disease if you're suffering from major depressive disorder, but the worse outcomes. Should you develop this disease, you're less likely to recover from it. Higher all-cause mortality, shorter life expectancies span, not by a little, but by a lot. 27 times greater likelihood of committing suicide, but not just suicide, of dying from homicide and in accidents. We know that suicide worldwide, women attempt more suicides, but men complete them more often. Men are 2 to 3 times more likely to be successful in their suicide attempt. This is called the gender paradox. They select more lethal methods. Okay. So what are some of the risk factors and barriers to health? Okay. More than 80% of people with mental health disorders live in low to middle income countries. Global average is 27% poverty rate for children and 13% for adults. 80%, remember that. 80%, let me get back here to this slide. 80% of the mental health disorders, and look at the rate of mental health providers. Okay, other risk factors. On average, 1 in 5 people in areas affected by conflict have a mental health disorder, and I suspect that this is low. Global threats, economic and social inequalities, public health emergencies. We all lived through COVID and are still living with it, and saw the impact on just about everything. In looking at the World Bank's poverty rate, we talked about poverty being such a big risk factor. Poverty had been going down over the last 20 years. Much of that gain had been erased over COVID. And while it's slowly catching up, it can't help but have impacted not only poverty, but the subsequent mental health. 27 million people last year needed humanitarian assistance. And in 2021, 84 million were forcibly displaced. And as we all know, that's happening today. The climate crisis. Extreme weather events have increased 46% since 2000. For those of us who live in the US, California wildfires in the last 120 years, half of them have happened in the last 20 years. So half of the wildfires have occurred in the last 20 years since they've been keeping records 120 years ago. We have floods, extreme storms, earthquakes, all impact mental health. Okay. Lower levels of mental health literacy. Low levels of mental health literacy leads to misconceptions about mental health, which Nora talked about earlier. Stigma keeps people, even if the mental health treatment is available, it keeps them from seeking mental health. And the digital divide, I can't under or overestimate how important this is. During COVID, the web, the internet became the way of providing counseling. I know at the University of Utah, our counseling was totally done online. While most of us who've done counseling would prefer not to do it that way, it was the way counseling was done for more than a year. And last May at the counseling center, following a goodbye brunch for the interns on Friday, the following Monday, 13 of the counseling center staff had COVID again. They were immediately able to change any remaining appointments online. And 3 days after being diagnosed, while they felt better, but still were testing positive, they were able to continue counseling online. This is not available for those who don't have good internet access, don't have computers, don't have reliable access. Information, treatment, support, all that are available are not available to those without that resource. So how do we drive the mental health agenda forward? I like this graph because it really looks at how we change it on an institutional level. You've got the express commitment. Most people have no problem saying they support mental health. Government leaders, our administrators at universities, everybody supports mental health. Institutional commitment is a little harder to come by. How do we establish policies and programs that'll make a difference? Institutional commitment sometimes happens, but then when it comes to the budget, things change. I mentioned that countries spend less than 2% of their budget on mental health. On average, 70% of that 2% goes to psychiatric hospitals, which means they are not investing in community mental health. They are not investing in preventive services. They are not investing in treating mental health issues early before they become so severe. Only 20% is going to community mental health, which is problematic. We need to reshape the environments where mental health issues are occurring. That's enough said on that. Okay, so what can universities do? First, we can provide access to mental health services. And this takes money. This means investing in mental health services, not just well-meaning people who are trying to help out, but actually investing in counseling centers, in preventive services. Not all schools have the money to do that, but the cost is very high. What we found at the University of Utah, and there's a lot of studies to support this, students who get counseling when they have mental health issues are much more likely to graduate, and their grade point averages are higher. It's worth the investment if our goal is to graduate students who go on to become healthy citizens. Identify and support students at risk. And by this, I don't mean hunting down students with mental health issues, but supporting those who come to our attention. In the US, unfortunately, it took a shooting at Virginia Tech to make us realize this, but we developed teams that are called care teams or behavioral intervention teams that are made up of a variety of faculty, of staff, people from our residence halls, people from the Dean of Students Office, from the Counseling Center, from the Health Center, who come together to develop plans to help specific students at risk. How do we help these students get the help they need? How do we help them continue on to graduation? Okay. Educate faculty and staff on their roles as partners in prevention, identification, and reducing stigma. On occasion, faculty and staff can be part of the problem. It's important that we educate them to know that even if there is a counseling center, our counseling center at the University of Utah is big. We have 24 clinicians, psychologists, social workers, counselors, psychiatric nurses, and then 20 interns from various disciplines. And they can't do it alone. The crisis is too high. They have to have partners who are willing to help out, to step in, to get the students the treatment they need. Okay. Build social resources to foster positive relationships with faculty and staff and other students. Nora mentioned the importance of that social connection. We're beginning to use the term belongingness a lot. Do students feel like they belong there? Do they feel like they have a connection, that there's people who care about them, that this is the place that they not only have chosen, but that have chosen them, that they want to belong there? Okay. Consider providing required social emotional learning classes. Often they're elective, and it's important that we make sure that there's an elective course there, but to be able to require freshmen, their first or second year, to take classes that teach preventive skills and that normalize taking care of the mental health is as important as physical health. All students come in knowing they should exercise and eat well, sleep well. But do they know that they should take time out for meditation, that they should focus on stress management? Not so much. Increase mental health provider training programs, particularly in the countries that don't have them. You saw that part of the issue is there are not mental health providers in many, many, many countries. Without mental health providers, how do we refer? And on top of that, providing education for primary care providers. So for nurses, for doctors, physicians' assistants, they should all know about mental health identification and treatment. For many people, this is the only health provider they see. How do we help make sure that those primary care providers know what they're doing? Okay. And then research and publish on mental health topics. Too often, research and practice are not connected. They need to be. And then work with local governments to make changes. I know that sounds easy, but ultimately, local governments need to be involved and to recognize the problem. So I want to close with this statement. And if you haven't read the World Mental Health Report from WHO, I would advise you do it. It's long, but it's got a lot of good information. Business as usual for mental health simply will not do. Many of us know the statement that the definition of insanity is doing the same thing over and over again and expecting different results. The business of ignoring mental health, of criminalizing it, of separating it, of demonizing it doesn't work. The cost is just way too high for the individual and for the society, especially when we know that intervention and treatment can make a difference. So thank you for the time, and I appreciate it and looking forward to the rest of our time together.
Thank you very much, Kerry, for very informative talk. We are seeing that a lot of comments are pouring in and a couple of questions as well. So we're going to take those questions towards the end. Quickly, we move forward to our next speaker, Dr. Iram Gul. Dr. Gul is Chairperson, Department of Behavioral Sciences at Fatima Jinnah Women University. Pakistan, and she's also the Director of Counseling and Wellness Center. Dr. Iram, over to you.
Thank you very much, Dr. Saida. You are going to share my
All right, I'm going to share this.
presentation. All right.
Dr. Iram, it's shown now. I hope the screen can be shared.
Yeah. Thank you very much. And I'll talk about evidence-based psychological intervention. But before talking about it, I want to introduce myself. I'm also a psychologist, and I'm the chairperson of the Department of Behavioral Sciences. I'm also working as a director, Counseling and Wellness Center. As Carrie has mentioned, they have a counseling center as well, but there is a huge difference when it comes to the counseling center at Fatima Jinnah Women University. We have limited faculty in the department who are also working as counselors. And some of our graduates are working on volunteer basis as interns in the counseling centers. So what we have done is that we have taken initiatives to enhance the overall well-being of faculty, staff, and community at large. And during COVID-19 pandemic, we have provided free online counseling services to the community. So we are committed at nurturing a supportive and health conscious community that promotes the holistic well-being of the individuals. So, and obviously it encompasses the physical, social, and emotional dimensions of the well-being. So in Counseling and Wellness Center, we are actively involved in a lot of activities. Some of these activities are webinars, seminars, similarly counseling camp. We do the counseling camps periodically so that the students, the new inducted students, and even students from other university and community join us and register for the counseling services. So we explain to them what are the services that are available and how can we go about it. Similarly, we do the walks every year. We celebrate Mental Health Week in October, and we conduct different activities like workshops, walks, even poster competition, so that the students should be able to express themselves, and they should be able to, we should be able to address their mental health issues and challenges. So we try to ensure that these services should be provided to the students, faculty, staff, and even the marginalized segments of the society. We provide these services to flood affected areas, to children and women in flood affected areas. And we also provide these services to transgenders and other marginalized segments of the society. So I think that we are trying to contribute, and we are trying to play our role as psychologist and as counselor in a public sector university. Now, what is evidence-based therapeutic intervention, and why we started conducting some small-scale randomized controlled trial? Because across survey, for almost 6,000 young adults, from majority of them were from the province of Punjab, but in other provinces as well. And we identified that from 55 to 65 individuals within the age range of 18 to 30 years were identified with significant symptoms of anxiety, depression, and stress. And similarly, when I talk about my university, every year after the new induction, we do a kind of their mental health assessment. A very, very, and obviously we maintain the confidentiality so that we could identify if somebody and screening it basically it helps us to screen and diagnose an early intervention. So why we so what is an evidence-based psychological intervention? Basically, it refers to um, Dr. Saida. I think um, this is not the no. You are using the old one. Let me share. Let me share it. Let me share
Okay,
the
Dr. Iram, I think
presentation.
it is the old one that I have.
This is
So
not the right. Yeah, yeah. Let me share the. You please you stop. Can you stop sharing so that
okay.
I can share mine? Yeah.
And we are just left with
Let
10
me.
minutes, so we just have to 10
Yeah,
15
yeah,
minutes. Okay.
yeah. So yes. So when we talk about therapeutic approaches and treatment in the field of psychology, we know that evidence-based psychological interventions are grounded in empirical evidence, which means that they have been shown to effectively address specific mental health issues and psychological challenges. Some of the interventions that I'm going to talk about today are derived from cognitive behavior therapy. Our main emphasis is on acceptance and commitment therapy, which is a form of psychotherapy that combines of cognitive behavior therapy with mindfulness and acceptance strategies. So it aims to help individuals accept their thoughts and emotion while committing to the behavior that align with their values and life goals. We have seen that acceptance and commitment therapy can be very, very helpful when it comes to um, pain perception, chronic physical diseases, and other issues such as anxiety and depression. The six core processes of acceptance and commitment therapy, which are very, very helpful when it comes to the youth as well. And we have used these kind of therapies with young adults. So some of them are cognitive diffusion, acceptance, commitment, values, self as a context, and being present. Now, if we move into the mindfulness based interventions, there are two type of mindfulness based intervention: mindfulness based cognitive therapy and mindfulness based stress reduction program. So again, these intervention basically emphasize on the practice of mindfulness, which being means fully present and non-judgmental about our thoughts, feelings, and sensation in the present moment. Um, when I'm going to mention some of the research studies that we have done, you'll see that mindfulness-based study, we were able to establish the efficacy of mindfulness-based studies in Pakistan and in young adults. I think that once and it has been very very effective when it comes to Pakistani culture. I think that religion in mindfulness play a very important role. So I guess there are certain strategies which we have used and which have proved to be very effective. Now, some of the evidence-based psychological intervention in Pakistan that I'm going to talk about. So these are the studies we conducted here at Fatima Jinnah Women University. And obviously, we collected the data from all over Pakistan. Some of these studies were conducted in different universities. So during COVID-19 pandemic, we sort of assessed the impact of mindfulness-based intervention on COVID-19 related stress and mobile addiction during pandemic. And it was a randomized control trial. Initially, we did a cross-sectional survey and we identified 327 people, out of which approximately 45 to 55% were identified with the symptoms of anxiety and depression, and 24 exhibited sign of mobile addiction. Mindfulness-based stress reduction program was effective in reducing traumatic stress within the intervention group. However, we have not seen any impact on mobile phone addiction because there were other factors which were playing a very important role when it comes to mobile phone addiction. Moving on to the next study, it was the impact of mindfulness-based intervention on parental stress among mother of children with autism spectrum disorder. As I told you that we have been working with the marginalized, the special children, the children with disabilities, or children who are suffering from different kind of neurological disorders. So we took 103 mothers of children, and again in a cross-sectional survey, finally we identify 40 mothers who agreed to participate in the randomized control trial, and the results again identify a significant reduction in parental stress within the intervention group at time 2 as compared to time 1. Now, the third study was on the hypnotherapy on post-traumatic stress symptoms, death anxiety, and psychological distress. Again, a randomized control trial, and we were able to identify a significant reduction in psychological distress as a result of hypnotherapy. This is again, we did a study where we use hypnosis for stress management program on anxiety, depression, and perceived stress among young adults. This program was effective in decreasing stress, anxiety, and symptoms of depression, and it also helped to improve self-esteem at time 2 post-intervention. Now, moving to the next slide, this is on the role of emotional and social competency in quality of life among young adults. And basically, again, we looked into the impact of mindfulness-based therapy. So here a randomized control trial was done, and we were able to enhance the social and cognitive sort of competency in young adults through mindfulness based. I think this is a very important study that we done. It was on psychological distress, suicidal ideation, and non-suicidal self-injury among young adults. Again, mindfulness-based intervention was very significant, and the alarming thing was that 42.9% were identified with depression, 27% exhibited high level of anxiety, along with the 10.3% experienced high level of psychological distress. So again, 30% reported high level of suicidal ideation. This was very, very alarming, and the mindfulness-based intervention, and we were able to reduce all these sort of psychological distress, suicidal ideation, and urge for non-suicidal self. So after conducting all these studies, I would say
Ms. Tayyiba, आप kindly, Ms. Tayyiba, can you mute your mic?
Effective, especially when it comes to the young adults in Pakistan. Thank you so much.
Thank you very much, Dr. Iram, for a very comprehensive overview of the work that is being done at the department. Obviously, these kind of interventions are related to the international audience. We now come to the closure of our first session, and we have very limited time. However, we have a couple of questions that have been shared. And just due to the time constraint, I might not be able to take all of them, but I'm going to just spell out a couple of them. I think the first question is again open to all of the panelists here. And the question is from, if I'm able to say your name properly, it's from Lindo Kyole Sibia. He's member of African Mental Health Association, and he says that we have various activities in mental health conditions. So how can we be assisted in tackling our activities? Probably, if any of the panelists can respond in terms of how activities can be enhanced or they can be improved. Kerry, would you like to respond to it first?
Yeah, let me, obviously big question. And for many of the audience, I know you're dealing with very limited resources. One of the things that we're doing with the Pakistan project is having those who are trained in mental health train those who are not in basic listening skills. Nora at the beginning talked about the importance of listening and how infrequently people are really listened to. So how do we identify people, whether it's faculty, whether it's community members who care, and then how do we train them to be good listeners? To not jump in and immediately try to solve the problem, but just to really be able to listen, to understand the questions, to ask the right questions, and then sometimes if there's no referral, to be able to figure out what are the next steps. So listening, hearing, not just listening, hearing, and then coming up with problem solving. There are programs and, well, let's say programs. I know who is working on one where anybody who has basic empathy skills can learn to be a problem solver. That's a start, is to find out who could do well with that without going through the graduate program of becoming a therapist, and help the community. That's one.
Thank you very much. Thank you very much. Dr. Iram, would you just very briefly cover or respond to the question?
Yeah, exactly. I would definitely support Kerry's answer. We are doing the same thing over here. For example, we are training people from different departments, and we are giving them workshop how to sort of identify the early sign and symptoms of mental health issue. As Kerry talked about, the fact that active listening, the fact that how to empathize with students or how to empathize with the clients, we can always teach them. So this is what we are doing. So in each department, we have a focal person and we are training them so that they can identify or at least listen to them or empathize with them. And in case they need referrals, they can always refer. So yes, definitely that's one way of doing it.
Thank you very much, Dr. Iram. And I would now like to take just the last question, and the rest of the questions we'll be following it up through remotely after the panel is over. I'll now like to address the question from Gurpreet Rana. Gurpreet Rana, if you are actually live, you can probably want to ask your question directly if you're available. However, the question is, would you address the disparities in mental health among women and girls that is often fall through the cracks, such as depression or postpartum? I mean, these are the issues that go neglected. So would you make a very quick comment, any of you, on this particular question?
It's possible that this will be addressed a little later with the second panel.
Okay, yeah.
There is a huge disparity. Although at least in the United States, women seek treatment at a much higher level, but there's, when you think about the term hysteria comes from the Latin word for the womb, thinking it's not a real symptom, it's a woman's issue. there tends to be a discounting of some of these things, of women not being able, it goes with the question also, I think, earlier about madness, that somehow it's a weakness, it's a madness, it's something that people should take care of in themselves. And the answer is to ignore it. And the postpartum depression, if anybody has suffered from postpartum depression, they know that this is real. It may be situational, but it's real while you're trying to deal with not only hormonal changes, but a young baby. Yeah. But to be identified, we still get back to availability of treatment. It's to recognize that it's real, to not discount it as something that just a woman suffers. Frankly, yeah. I often think when I was at the counseling center that women were the brave ones because they could admit that they had a problem and seek treatment, and men less so.
Thank you very much, Kerry. I'm sure a lot of you have more questions to come, and we'll try to respond to them as the session proceeds. So we are extremely grateful to the three panelists. Thank you for joining, and I hope you remain with us for the rest of the webinar. Next, we move on to our next session, and for the international audience that is here, people are joining from different countries. Our next panel is basically of our experts from within Pakistan, different provinces, and they'll be sharing the contextual factors associated with mental health in Pakistani context. And kindly don't hesitate to share your questions through the chat box once again, and we'll request the panelists to kindly go through the question answers, the tab, and if you want to, you can respond to those questions as well. Kindly do turn your mics off if anybody else is there. First, I'm going to invite Dr. Nadia Ibrahim. She's a lecturer at Peshawar University Department of Psychology, and she's joined by her peer, Ms. Tayyiba Atif. Tayyiba is currently working in New Tech as Director of Student Affairs. Kindly just proceed with your presentation and briefly introduce yourselves to the larger audience. Over to you. Thank you.
Hello, everyone. Thank you for inviting me here. I'm Nadia Ibrahim. I'm a clinical psychologist, and I'm a lecturer at the University of Peshawar. And here I'll be briefly discussing the factors which in our university the students are experiencing that may be leading to the mental health issues. I hope you can see the screen that I'm sharing.
Yeah, it's visible.
Okay, so and I hope you're seeing the whole screen and not just the major part. Okay, so here I wanted to highlight the different factors we in our university have experienced students having certain issues. So I'll be highlighting those. These are usually not just limited to our university, but the universities within our province, and some of the problems are those which are not just in our region or our province, but throughout Pakistan. So I'll first start with the switch to semester system. Now, for us in Pakistan, till 12th grade, we have an annual system in which they have a final examination, and they are given marks or grades according to that. But when they come to university, the universities have semester system, which is just as it is in the US or internationally, that you have a midterm, you have a final term, and then you have a class assessment, which can be anything, a test or a presentation or a model or anything that teacher thinks suits that particular, you can say, subject. But there are both benefits and barriers for this semester system. One thing that is beneficial is that it provides flexibility to the students, because the student, if is not getting good grades in mid, may make up for it in the final. Similarly, there are many different opportunities for improvement, but the semester system also comes with certain pressures. This doesn't give you longer hours for you to study deeply, for you to study a topic in depth, and there is continuous assessment. So the students are all the time on their toes, and this may increase the level of stress in them. This may increase depression in them, and because of that presentations that are there, these students may be experiencing anxiety, because in annual systems they do not have those presentations usually. Now they have to come, take a stage, and they have to communicate with the students, so it becomes difficult for them. Then some universities, they have relative marking in the semester system, so this is another problem that the students have, because they do not have an experience of that in annual system. The next major problem that we have, which is in part related to the annual system, is that in annual system usually there is that rote memorization which students do. They're given a certain book that they have to use. Within this book, they have, for each subject they have different topics, and they have to just memorize them and reproduce them in their paper. As opposed to that, in semester system, they're given conceptual paper in which anything can be asked, but they just only have to learn the concept, they have to learn the idea, and then they can be asked about it. Now the problem with this is that the students who have had an experience of 12 years with that rote memorization, they find it difficult how they can communicate the ideas that they have in their mind. Sometimes they have learned the concept, but they do not know how to use different words than those that were used in the book. The other problem with this is that sometimes, like for example in COVID, we could not take the physical examination, we could not conduct the physical examination for them, so we were making the use of the internet, and we were sending them online papers, and most of those online papers were conceptual, because obviously they had access to books, they had access to internet, so we could not give them a question which had an answer from A to Z, or which had an answer from page 1 to page 3. So they had to be some papers or some questions which were in conceptual in nature. Now the students were failing in that, and they were finding it difficult. I had my students who came to me and said, ma'am, we have put that question in Google, but we cannot find the answer to that. So this was because of the fact that they were so used to with that rote memorization that they were finding it difficult now. Still another problem that we see, and this is not just happening in Pakistan or a certain region in Pakistan, this happens internationally, that the students, they have to continuously have this fight, or they have to maintain this balance. They have parents who come with their own expectations, and we have in psychology learned that there are fixations that have happened. So maybe sometimes the parents have not achieved something, they have not become a doctor themselves, they have not become maybe engineers themselves. Now they want that to happen for their children, for their offsprings, and this puts a great pressure on these students. These students, they have to sometimes fulfill those expectations which are not even according to their own abilities. The parents are not thinking of what my child is capable of, or the different children, they have different abilities. Some are good in art, some are good in math, some are good in English, but the parents, they want their child to be perfect. And this is particularly true for the Asian cultures and in Pakistan, that we go for grades, how many grades, or even the parents, they compare the grades of their children, so that becomes another problem for them. Now this is one thing that they have to face, and on the other hand, they have this peer pressure that they have to deal with, because the students, they are having friends who want parties, who want going out, who are using mobiles, who are following trends. Now they follow the parental expectations and go for becoming a studious person, then they'll be judged by their peers. If they go for their peers and they follow what they are saying, then they are going to face consequences from their parents. So this difficult situation can lead these students to experience different mental health issues, which can include social anxiety, this can include avoidant personality, this can include even sometimes antisocial personality. This person can develop certain conduct issues, or there can be many different problems that these students may experience as a result of this lack of balance. Now, in the recent times, what has happened is that earlier the Pakistani students, they were not much concerned with the relationships that they have with the opposite gender. But because of the this social media, because of the peer pressure, they have come with this idea that they have to form some relationships with the opposite gender, and those who do not have it, they want to have it. Those who are having it, they are sometimes not mature enough to deal with certain multiple roles. So this is causing them problems. Another problem that they are facing is that sometimes they're having breakups, and because of these breakups, these students come to our clinics, they want therapy, and they are going for they're like having suicidal ideation. Some of them, they experience poor self-esteem because they think others are having relationships, I'm not having it. Maybe there's a problem with me. They have come from usually the segregated institutions, and now they have come to co-education, which is another barrier for them, which is making it difficult for them because they have not had any interaction with the opposite gender before. So this is also another problem that they may be facing, and this can lead to certain mental health issues. Now, as you or many of you may know, that Pakistan, even the whole world, is coming across with financial pressures. There are students that and they are facing problems because their parents are facing financial problems. And the problem with Pakistan is that internationally we see that students, they're given different opportunities. Even within university, they can take a part-time job at the canteen. They are given the jobs of teaching assistant. They are given jobs at the library, or even outside they can take a job at any store. They can do different kinds of part-time jobs. But in Pakistan, there is a stigma associated with that, and these students, they're incapable of generating their own resources, their own finances, and because they are at university level, so they find themselves a burden over their parents. Because in Pakistani culture, we'll be talking about our culture, it is a culture in which the children, they are with their families, no, even after 18 years. So they feel that they are a burden on their family. Yes, one thing that our students have done is that I have given here these different Instagram links or pages of some of our students who have started some businesses which they are promoting on Instagram. Some are painting, some are doing crafts, some are doing bakeries, home-based bakeries. So these are the different things that they are doing, and they're generating money through it. But this is a very limited, you can say, resource that they can generate through it. Then we have cultural issues, cultural values that we have in Pakistan, and particularly in Pukhtunkhwa. They are very different than the outside world, than the other countries. The culture that we have, it promotes passivity, it promotes the respect of others, and that respect means you have to be completely selfless. You have to walk under others' guidance. You have to give respect to the elders. You have to listen to them no matter what they tell you. You have to accept whatever the society is telling you, no matter what it is. And most of the problems that are being faced are by our female students, because they have certain limitations. They have to move around in them. Yes, it has changed from the past. Now when we look at it in our department, for example, even the faculty, we only have one male faculty, the rest are all female faculty. So yes, for students also this is changing. We have a lot of different students who are females, but still there is that limitation that we have. And because of all these cultural values, what is happening, that our students, they are becoming pessimist, they are becoming passive aggressive. They cannot express their aggression. They experience frustration, which may in turn lead to depression, because they are not allowed to go out, they're not allowed to explore. What happens is that they experience social anxiety. Similarly, they they show passive aggression, as in they cannot directly stand in front of their parents or their authority figures, so they experience those different problems. Similarly, these students, because they are unable to express themselves, they're also coming across with the problems of lack of assertiveness. They have poor self-esteem. They do not feel that they have self-worth.
Nadia, if we can quickly wrap it
Yes,
up.
yes. I'll try to wrap it up. Now, marriage before completion of degree is both a problem for our male and female students, which lead them to have multiple roles. Now, these multiple roles again cause problems for them because they have to study, they have to take care of their families, then there are early childbirths for them. So that also is a problem. Yes, they are above 18, but still they are young enough. They are not having that much time to deal with all that. Then we have students from underdeveloped areas. It means their schools are overcrowded. The institutions that they do not have the facilities, the multimedia, the libraries. The teachers are not qualified enough. So this is then creating that barrier. So when they come to the universities, which are in cities, they have these all these facilities, and they have all these different students who have come from colleges or schools in this area. So they are more confident, they have a higher self-esteem. So this is again a problem for those students. Now, some of the students, they have or majority of the students, they have lack of awareness. They do not know what is a disorder, what is a mental health condition, what are the etiologies behind that, how can they deal with that. Even the families, the parents, they are not caring for that, they are not having the knowledge about that. And even if they do know, there is a stigma that is associated with mental health. Students within our department of psychology, even they feel embarrassed, or they feel that they'll be judged if they come for mental health. Finally, I'll talk about the teachers as well. The teachers, they also have mental health issues because of certain factors that the students also have, like the financial pressures are same for them, like the values, they are same for them. But teachers, they have workload, and if we say there is semester system, they have to check continuously these papers, they have to mark the assignments, they have to do research work, and they have to deal with the problems that the students are facing. If students are failing, this is another problem for them. They have to take care of the students who are from the underprivileged areas, and from the students who are from those privileged areas, they have to deal with them side by side within that same class, which is another problem for them. So I'll cut it short now, and this is it from my side. Thank you very much, Dr. Sajda, and I'll now let Miss Tayyiba, to take
Thank
it
you.
on from here. Thank you.
Over to Tayyiba, please. Tayyiba, you might need to unmute your mic, please. Unmute yourself. Are you able to unmute? Okay, now it's
Yeah.
fine.
Am I
Thank
audible
you.
now?
Yeah, you are. Thank you. And you can share your screen as well, or you want me to share the screen?
Yeah, kindly share my PowerPoint, please, Sajda.
Okay, I will.
Okay, so Assalamualaikum everyone. I'm Tayyiba, and I work as a student affair officer in New Tech University. And working close to students, I opted for a topic that I really wanted to talk about, that is becoming a support for our teens in coping mental health issues at domestic level. As we all know that mental health professionals in Pakistan, the number of mental health professionals in Pakistan is quite low in number. So as a layman, what I expect from ourselves, everyone, every person who is a psychology major, that we take this mental health perspective to a level that everyone is can work with our in collaboration with us. Like, what can we offer as a layman approach? What minimal we can do is that be the first point of our moderators and facilitators for the kids around us, be it in our family, home, workplace, or anywhere, to detect the early signs of mental health issues. This approach is as simple as just to be available to listen to them. The more focus which I would say that is active listening is the major part of what I would suggest that we can follow as mental health professionals, and we can make our kids, our younger siblings, or whatsoever children, teens we have at our home, at our neighborhood, at our university, schools, that we have to make them realize that it's okay to not feel okay, and we have to normalize the concept that uh, whether you are feeling happy, whether you're not feeling happy, someday you are in good mood, someday you wake up in not in a good mood, it's a completely normal, and you have to share with any person comfortable you are comfortable with. Okay, one other thing is that we tend to always school our kids about discipline, which may lead them to project our behaviors in rationalized manners, that we are always generalizing the concept that if my kid is getting up from the bed in a happy mood, then he or she is a perfect kid. And this is the concept that we have to make minimized. Rather than always judging them, we might emphasize that how exactly they are feeling. And as a layman, we can ask questions casually to our kids, like how was your day, did anyone hurt you today, what made you happy. These questions can enhance the communication skills of the child, and at the early stage of their life they will be made realize that this is something to share. The feelings, whether good or bad, they are enabled to share those feelings, and eventually when they'll be feeling any mental health issues, they won't be reluctant to seek help. And this is the main crux which I want, that this should be emphasized from us. Do not associate gender roles in expressing the way kids feel. Most of us are listen to, like, why are you crying, you are a boy, or why are you shouting, you are not a boy, you are a girl. We need to minimize these things. We should not generalize roles in expressing the way kids feel. This will suppress them as a boy. This will The boys will eventually learn that we are boys, we don't tend to express our feelings, that we are not feeling okay. So look for the ways to check in with your teen. Ask them how their day has been, what they have been doing. It could be by inviting them to join you in a task. For example, you are preparing lunch for your kids, and you can involve them in discussion that how was your day and what made you feel good or bad. Remind them that you are there for them no matter what, that you want to hear they are feeling and what they are thinking. A few words of encouragement can help them feel comfortable sharing their feelings with you. Be honest, be transparent. What is their conflict? Take time to reflect on how and your teen can resolve it. Like, if if your teen approaches you with any problem, you can relate it with the way you used to face those problems and how you catered the problem, and this discussion may lead to lack of confidence. Take the time to support them, work through conflict together, listen to your teen's views, and try to sort out conflict calmly. Okay, now another important thing which I wanted to discuss was establishing a connection with your team. The first thing that comes, which is very important, is build your relationship. And this can be done into many ways. Like, first of all, you have to give importance to what they are saying and what they tend to express. Show interest, and this shows that you are giving them importance, what is important for them. Share things about yourself and find ways to make connections. Ask your child about their opinions, views, and build the communication. Another and the most important thing is be an active listener. As a student affair officer, this is the most important and most useful thing which I always do with my students. I just whenever any student approach me for any XYZ reason, I just put up my everything behind. I just lean towards them and just listen to them actively. And believe me, that's so powerful that this gives them the confidence to whatever they are trying to express. And listener is engaged, caring, non-judgmental, and empathetic. Give positive feedback and affirmation, like adding into the sentences like "Thank you for being brave and sharing how you're feeling right now," etc. And also, "I'm glad that you shared with me." That we have to encourage them that they are here to express their issues and they are being heard. Validate what your teen is expressing. This can help teenagers accept their emotions and feel safe to express themselves. Lastly, communication is not only about sharing the difficulties or sharing what bad experiences they have been feeling. It is important to share funny things or whatsoever good opportunities or laugh together that will definitely have a strong relationship, build their relationship, and they will, it's a wonderful way to feel good and strengthen the relationship with your teens, and they will give their confidence to be more open about their emotions, and if they are feeling any mental health issues, they will be more prone to discuss with you.
Thank you very much, Tayyaba. It was very informative to learn about how we need to respond to children of different needs. And thank you to both of you for sharing your thoughts about the cultural context. We now move on to our next set of panelists. Next, we are joined by Ms. Anka Gershin. She's representing Butums, and I'll now like to invite her to share her views. And along with her, we are joined by Ms. Noreen Lahiri. She's representing the University of Sardar Bahadur Khan Women University. Both of you kindly share your views about what do you see in your context. Thank you.
Okay. Dr. Sajda, can you hear me? Should I start?
Yes, I can hear you, Noreen. You're going to start first.
Thank you so much, Sajda, and the entire team for giving us this beautiful opportunity to share our views, thoughts, and issues related to, particularly to Balochistan, the province from I belong. My topic is gender-based violence and its impact on students' mental health. So, change the slide, please. I would like to briefly introduce myself a little bit, that I am Noreen Lahiri, and I am affiliated with Sardar Bahadur Khan's Women University, Balochistan, and this is the only female university in our region, including 3 sub-campuses in different parts of our province. So when we are talking about gender, I would like to little bit elaborate this content, that why it is important for me. Because earlier when right now I'm affiliated as Assistant Director, Human Resource Development Unit, and counseling, career counseling and mental health well-being is one of the components that I'm leading with. And apart from this, I worked with different civil society organizations and work in my entire country, focusing the gender disparities, gender issues, women and girls issues in Pakistan, and particularly in my region, Balochistan. So this was my area of interest as well, and that is one of the key factor or the fundamental point that why I want to elaborate that why it is important for us to understand the gender perspective, the gender-based violence perspective in context of mental health, because it is very important, and at the same time, in many areas, still it needs a clarification, a kind of conceptual understanding on GBV and its impacts, especially on women and children. So when we are talking about gender, I would like to a little bit elaborate that what do you mean by gender? Gender is referring the different characteristics, the social roles, responsibilities that has been assigned by the society, particularly for men and women, girls and boys separately. So we can say that we have two different worlds. One world is for women in context of gender role, and the other world is for men. So when we talk about the issues in general on health or mental health or related to any social issue, we have to look into these different worlds that has been created by society, by patriarchal society, and it has its own impacts and negative impacts. So we have to understand that there is a world, but within this world, we have two different worlds for men and for women separately. And gender refers the roles and responsibilities of men and women, girls and boys differently, that constrained and built with the passage of time with their, when they are nurturing their children, the boy and the girl, they are differently, their brought up is entirely different in society when we are talking about gender. Next slide, please. In context of, next slide, please. Next slide, please. Adga, can you hear me? Sajda, can I have the next slide? That is, what is gender-based violence? Yeah. So when we are talking about gender-based violence, it refers to any type of harm that affects a person, a man, a woman, because of their factual perceived sex or gender. And gender-based violence is a violence directly against a person. It is against any act of about a person because of their gender. Both men and women experience gender-based violence, but mostly the victims in Pakistan, and particularly the victims in Balochistan, that are girls and women. So this is how we should look into the mental health and stress issues in context of gender-based violence, because majority of the affected or the victims of gender-based violence are women and girls. Next, please. Here are some types. Most of you are working as psychologists and psychiatrists, and you're familiar with them. So I just briefly highlight the major areas that are physical violence, mental health violence, mental, physical, and sexual health. But apart from that, we have the harassment, the verbal and the non-verbal violence and its impacts on society. Later on, my colleague Anka will talk on it. And we have some sort of, sexual violence in societies like Balochistan. We are not supposed, the women is not supposed to talk about if they are victim of sexual violence. They are not supposed to talk about it openly. There are some cultural restrictions. There are some social constraints and religious and other counting factors that limiting women not to talk about their sexuality or about their sexual violence, if particularly if they are victim of sexual violence. Similarly, we have the socio-economic, like women are not allowed or might be dependent to ask the family members, the male family members, to spend the money or to develop their budget or to work on or talk about the economic situations within the family, and even about the in the context of the broader economic context of society. They are not supposed to take decisions individually. The political influence in the violence is also there. I worked in KP and in different parts of Balochistan. So most of the women, when I interviewed them for a research, documenting a research, they said we are not supposed to cast a vote without the permission of our males, and we are not supposed to choose the leader of in elections. So this is how I personally and look into this as a kind of violence, that they are not supposed to even to make decisions within the family on small to big issues in society. Later on, we have the activities that are related and influencing and including and incorporating, increasing the violence within the families and within the society, that are around physical, mental, and sexual harassment and assault. Next, please. If we look into the causes, because I'm supposed to, we have very short time and gender is a vast subject. And if you will talk about the different types of violence and its impacts and then the causes and the reasons. So it will take too much time. I'm just, giving a brief description and an intro of my province related to the university, that there are a number of causes that are the main reasons of gender-based violence. They are the patriarchal society. As I earlier mentioned, that Pakistan and the underdeveloped countries are mostly patriarchal societies where women are supposed to be treated like subordinates or the second citizens in country. I have the negative social behaviors, like if a woman is getting divorced or want to get divorced or get separated, and getting separated from the marital status to become a single one, so she has to be face so many social pressures, and she has to be face so many social behaviors, negative behaviors within the society, particularly from female side, because due to the lack of education or awareness, or without realizing that how much pressure the female is going through with this kind of behaviors or social behaviors that is impacting her health overall. Unequal power relationships, this is another cause, because whenever we look and talk about the gender or gender-based violence, we will find a big difference of power relationships and the balance of relationships within family, within the working spaces where working female are working, and then overall in the tribal society, we look into the deep roots of any tribal society. Female and male powers are not equally distributed. They have less privileged than men. Similarly, if we talk about the economic disparities, mostly women are dependent on men. They are not independent, economically independent in their families and particularly in their societies. Harmful cultural practices. This is related again with the social behaviors. Lack of education, this is one of the reasons, because most of people are not aware with the gender-based violence and its long-lasting impacts on students, on women and girls. So lack of education is one of the cause, and particularly if we look into these universities as well, so most of the faculty members are not even bothering themselves that if a female is constantly, or the student is constantly under depression and she is not performing academically very well, so they should bother themselves to go deep down and understand what are the reasons that why she is not properly performing in the classroom. So lack of education, lack of interest, lack of awareness is also one of the key elements. Disability is one of the key factors. I would like to highlight that when we are talking about the special people, if a man is disabled or especially different from the others, so he is not facing that much pressure as a man. But the female, because she will be treated like you're not going to be married, you're not having children in future, so she will be pressurized more than a disabled man. So again, this is a gender-based discrimination or a disparity in society. Being a minority, this is another gender-based discrimination, that if you are a minority, and particularly in universities or in other development departments, we look into this issue. So the being minority in itself is a cause of a gender-based violence, increasing the gender-based violence. Next, please.
I would just request the presenters to just that the time limitation is there.
Now I'm going to conclude it briefly. If you talk about gender-based violence impacts on girls and women, so it has different impacts on boys if we're talking about the violence in general. But if particularly we talk about the gender-based violence on women and girls, it has different impacts on them. It has impacts on their health, on their mental health, on their physical health, on their progress, on their academic progress. So the difference is very obvious. Students who had experienced any type of gender-based violence during their lifetime reported consequences of physical violence, including poor school performances. This is the context of Balochistan. Then 80%, 18.7% withdrawal from the schooling because of the gender-based violence. Female students are withdrawing and dropping out from the schools. Next, please. Generally, as I mentioned, that the impacts are also on physical. If we look into their health conditions, poor health nutrition, illness, chronic attacks, anxiety, anger. If they are doing, they are facing body shaming behaviors or comments from society, so they are, going introvert and isolation. And at the end, we can see the impact on their mental health, that they might be thinking about committing suicides and all that. Next, please. There are some facts that are related to our rural area female education and literacy that I'm not going to read one by one, but this really limits gender-based violence, really limits the girls to get education in interiors of Balochistan, and particularly to get higher education in Balochistan because of the tribal obstacles, because of the access to the information, access to the girls' education, and priorities in context of gender. Because whenever you're talking about parents, if they are facing economic issues, they will prefer to push the boy to get higher education rather than their girls. Next, please. Here are some solutions and recommendations. That first of all, I feel that strongly recommend this one, that we should collect data of dropout students, particularly if we are running working in a women university. What are the reasons that they are the students dropouts? Identification of gender-based violence affected students. If there are some visible cases, the physical violence is very obvious. Someone can see the impact on their health. So the students, the teachers, the group can identify them. Creating support within students and within university, as we started has a mental health wellbeing center, and started counseling of students and parents as well. Creating support for them within faculty. This is one of the area that needs to be improved, that faculty is only concerned about the semester system, about the content, about the subject, but they're not connected with that one individual for their grooming, for their self development, to help the student to get out of that stressed the issues that are making her stressed, and that is increasing their anxiety. So the teachers should be familiar with the GBV concept and with the mental health concept, and they should be very helping. Making proper arrangements for disabled students within classrooms, and especially for pregnant women. There are a number of students who are pregnant, but they are treated like normal people. Though pregnancy is taken in many countries like a normal thing, but still they need some physical space, some relaxing spaces within classroom, and even within the duration of entire semester systems when they are getting pregnant. So there must be a mechanism which help them to get their education complete with relaxing minding. Enhancing families through educational sessions on GBV. Yes, this is very important. Institutions, universities should engage parents to understand the gender issues, the GBV issues, the harassment issues in context of our region. And there should be a support. We should create a support mechanism for the students within family as well. So this is how the student help. Here is the teachers help, faculties help, and the family support is also there. This is how we can reduce the gender disparities or the mental stress of a student by creating a supporting mechanism within university, amongst the students, and within the family.
Thank you very much, Noreen, for sharing your insights related to your province. And I can see a dialogue going on in the chat box as well. So I hope some of your queries and comments have been addressed. And I would request the panelists to kind of comment as well. I would now proceed very quickly to Anka. Kindly introduce yourself and your background. And we are left with one more presentation before we move on to the next session. So over to you, please.
Hello. My name is Anka. I'm from Butams. I'm teaching psychology there. And today my topic would be about mental health issues and its impacts on faculty and students in context of harassment. The gender-based violence part, Noreen covered it, so I would be covering the harassment part. harassment and different aspects of harassment. So first of all, what is exactly the link between mental health and harassment? So we'd be also talking about different aspects of harassment, which can also mean sexual harassment, bullying, teasing. Sometimes people don't cross the boundaries between teasing and bullying, and sometimes it gets to sexual harassment. And sometimes in our part of the world, there are people who don't exactly know the boundaries between them. So if there is anything that is uncomfortable to you, if it is something that is violating your personal space, violating your body, violating your rights, it is harassment. And sometimes we misuse the word a lot. If there is a person who has aggressively commented on some of your views, the next person could say that person is harassing me. Okay, there's a difference between harassment and sexual harassment. So sometimes I think we should know the difference between both of them, because sometimes when we say somebody's harassing me, I should not take it as something as if they are sexually harassing me. So again, sometimes whenever we are reporting harassment, people don't make the distinction between them, and they ask some uncomfortable questions. They do not, they're not willing to understand, and sometimes they take the conversation entirely to a different area. So, and then we of course also have some racial biases, stereotype, ethnic harassment. Somebody, if they are having prejudice because of your color, your race, your gender, again, that is also something that comes into harassment part. So prevalence of harassment, I wanted to share some stories because I had been a part of disciplinary committee in our university for 2 years. And my part was mostly because I was a woman, not because I am belonging to the psychology department. My part was not to assess their mental state, but to provide a gender balanced system. So we have many cases, mostly of women, mostly of our female students who would have their pictures leaked, who might have threats online, who would also have male students following them to their homes. And all of those things disturb one's educational experience when they are at university. Even if we recall our educational experiences when we were students, harassment was something that we were all afraid of, that we didn't. In Pakistan, there's a culture of bullying new students. So the students who are freshmen, who are coming in the university for the first time, there is a culture of teasing those students, maybe sending them to wrong classes, maybe bullying them, and sometimes also sexually harassing them. And those cases are rare, but those cases are there. And sometimes students, because they are new to the university, they don't know who to talk to, who would help them. They are mostly clueless about the whole system. That's why they don't talk to anyone. And that's why they are the best or the most vulnerable target for those students who are seeking power through harassment. So again, forms of harassment, we have bullying, teasing, harassment, and sexual harassment. Again, all these four are different, but they have a very thin line between them. Bullying can turn into harassment. Bullying can even turn into sexual harassment. Eventually, if it is all four of them should not be there in an educational system, because again, we sometimes encourage a hierarchy. In our culture, any student who is a senior does hold some power over junior students. We might ask them to maybe, I'll give you notes, or I'll give you some books if you do this for me, or if you do my assignment. So all of these things come into harassment, bullying, and teasing. So impacts impact on students. Again, I have to link all of this with the students' mental health as it is related to students' self-esteem, their educational experience, and how it impacts. So, of course, a student who has been multiple times has been a victim of harassment could have anxiety and depression, anxiety because that student might would be not be able to focus in the class, and might not even be able to tell their parents because of the shame associated with it. Post-traumatic stress disorder, for some students, it can have an enormous impact. And low self-esteem and self-blame, sometimes when we cannot make sense of anything that is happening to us, we blame ourselves. So a student might blame themselves for not being as confident, for not being as vocal, but in reality, it is not students' fault who is the victim here. So it is the fault of the system, which is enabling those students to have an environment where they can practice harassment and bullying. Trust and relationship issues. We might have trust issues with male gender if we are getting harassment from them. So sometimes students might not want to make friends with them. This is a possibility. We used to have an openly transgender student in our university. She has been graduated. So right now we don't have any student who is openly transgender, but our student used to tell us how horrifying it was for her, specifically because she was identifiable, she was openly trans, and how harassment towards her was far more worse than as it is to female students in our campus. So of course there is an intersectionality, and there is some people might face harassment more than others, as some disabled students can also face harassment more than others. Of course, there's an impact on academic performance. Anxiety and depression can result to sleep disturbances and increased risk of substance abuse. Students might use different drugs to maybe to calm themselves, and physical health problems that can happen because of stress, as students tend not to eat, or maybe eat excessively, or use drugs, or not get enough sleep. All of these things are related to each other. And fear and avoidance, maybe there are students, I have seen students who fear to take classes if they are being harassed by some teacher. They fear to take get involved in a group exercise, in a group research, because one of those students was their bully. So these are things that impact students' educational experiences to a much degree. As I discussed, there are some students who are much more vulnerable towards harassment, sexual harassment, bullying, and teasing. And those students could be students with disability, again, students with visible and non-visible disability. They both can be a target. Female students and students who are transgender, they also can be a high target, as they are much more vulnerable than other students. And students having learning disorders, students, autistic students, students with ADHD. I also wanted to talk about impacts of harassment on faculty. Now, of course, it is very much possible that male members of our society could also feel harassment, sexual harassment, but it is the reported cases are less than 1%, while most of the cases are by female faculty and female students. So most of the impacts on faculty is very much similar to what was the impact on students. Their students' academic performance can be affected, while with teachers, their work performance could be affected. They might not want to work in group research with those teachers who are potential harassers, maybe, who are somebody they are not comfortable with. So though did want to talk about the real life stories which had happened, that there are some female faculty members who felt harassed by male students. And there are some powerful male students who might be rich, who might be belonging to powerful political background, who would feel that they are more powerful than teachers in the university. So it does happen. As I told, it is a power relationship. It is not exactly the harassment and the bullying. All of this is fueled by the sense of power you have on the other person. So there has been teachers who report that they have been asked for pictures, for hand in marriages with faculty members who are already married and having children, and many favors that you can understand any teacher could have when a male faculty member is sexually harassing them. So unwanted favors, all of this includes, and sometimes teachers do ask student that they would not approve their research proposal unless they come and sit with them in their offices, unless they talk to them, unless they maybe give them some other favors. So there are some stories which I heard while my time in the disciplinary committee. I'm no longer in the disciplinary committee, but the time I was there was nearly 5 or 6 cases that we had to deal with them every week. So coping mechanisms, these are the coping mechanisms that teachers and students can do themselves, like group catharsis, maybe talk about these issues together, strengthening resources like strengthening your family bonds, your friends, and bonds with your colleagues, and strengthening material resources like having hobbies, learning a new skill. Sometimes we don't know what our coping mechanism is or what would work the best. So trying new things really does help in understanding what works for you.
Anka, we might need to just sum it up.
Yes,
and,
I think
because
I
we are
have
just short
slides.
of time. Okay.
Yes, I think 1 or 2 slides. One, so university policies which we have are that we do have a place where you can report. What we can do as mental health professionals is raising awareness about those places where you can report about these things. You might even want to report to your counselor or to the disciplinary committee that your university has. And yes, there it is. This is all I had to share today. Thank you all for joining.
Thank you very much, Anka. Thank you very much, Noreen. I think this is a very huge topic to cover, and we need a lot of more time to address. But you have very, effectively addressed most of the things our students and even faculty are facing. As we are moving to our last session, I would like to mention that our students, there's a special session which is led by our students. But before we go on to that, there's a very important talk that is going to be delivered by Dr. Moti Ram Bhatia. I'm not going to introduce Dr. Saab. He is associate professor and chairman in the Department of Psychiatry at People's University of Medical and Health Sciences for Women, Nawab Shah. And we would like Dr. Saab to share about his experiences regarding student support services, and then we'll move to the next session. Welcome to the webinar, sir, and can you proceed with your presentation?
Thank you. In the name of Almighty Lord, the most merciful, the most beneficent, I'm thankful to all of you, especially Dr. Sajna Das, who given me the opportunity to talk about this topic. All have given a wonderful presentation with a valuable knowledge and experience. So, am I audible?
You're audible, and would you like to share? Would you like me to share your presentation?
Yeah, if possible.
Yeah, it is okay.
Actually, my topic is to support the people who present with the mental health problem. Please, next. No, second one slide. This is, I think, second last. I am talking about the second slide. Go back, go back. Yeah, second one. These are the objectives of my today presentation. We will discuss basically what the mental health is and what are the illnesses, what will be the impact of mental health problem on the population, and how to diagnose and whom to have the diagnose. And in the last, we will discuss how to assess and approach the patient with the mental health problem with the conclusion. If we define basically what the mental health is, this is a successful performance of mental function in terms of thought, emotions, behavior, cognition, as well as the perception. But next, according to the WHO, next please. Okay, Dr. Saida, can I move slide by myself or not?
You can definitely use your slide. If you want, you can slide share as well. Do you want to?
Yes, if possible.
Okay, then I have stopped sharing and you can share your screen now.
It is not showing.
Actually, you have probably shared the wrong tab here. Maybe it is in your.
Okay, okay, please you do by yourself kindly.
Okay, that is totally fine. I can share as well. You have to stop sharing, Dr. Sa. Kindly press the button of stop sharing. So here we go. It's the definition.
Yeah. Yes, according to the WHO, the World Health Organization, they have mostly divided the definition of the mental health in the four component in which the individual realize his or her own abilities, cope with the normal stress of the life, work productively, and contribute into the community as well as in the culture. So what the basically mental illness is? The mental health problem not only make the change the thinking of a patient, but it also affect the emotional state, behavior, cognition, as well as perception that may affect the work, daily routine activities, and the relationship that may lead to the deterioration of the psychosocial functioning. It may lead to the improve it may also affect the quality of life of the patient or the people. Next. As we know, the most of a psychiatric disorder occurring in a young age. In our country, about a third patient who attending the medical or the surgical OPTs have a psychiatric disorder according to Dawson, and 1 out of every 5 people is suffering from the mental illness. So a young age is a productive age in which the student enter into the university. If a patient is suffering from the mental illness, is not only lost the productivity of him or herself, but it also affect the culture as well as the country. Next, please. So look at, and can you go back, please? So look at the 50% of the mental illnesses occurring in a young age of 18, and by the 25 year of age, the 75% of the people has been affected. Yes. So it is not necessary a mental disorder should be diagnosed only by the psychiatrist, but also by the general practitioner as well as the psychologist by assessing the tool of the DSM-4 or the ICD-10. The ICD-10 is mostly is a British international classification of the disease, but the DSM is mostly supervised by the American Psychiatric Association, the Diagnostic and Statistical Manual. These are the tools. So, because of the stigma, people are avoid to consult with a psychologist as well as the psychiatrist. Mostly, the can you believe 11.7% of the people should consult for the mental health problem toward the psychiatrist. And look at this, the depressive disorder in the 59% of the depressed patient, they consult for their illness toward the psychiatrist, psychologist, and the anxiety 38%. While the substance use disorder, 25% of the people have to consult toward the GP or the psychiatrist. These are the neurotic disorder, while in the psychotic disorder as well as the dementic patient, they mostly don't know, they have no insight. So mostly the family members or the relatives bring them towards the doctor, towards the psychiatrist for their treatment. Because of the stigma as well as the poor in sanitary situations, poor mental health, that may also lead to the poor physical health as well. 11.7% of the people are living with the mental illnesses has the experience of physical disorder because of a multiple reason like of a medication, poor health, socioeconomic condition, medications, as well as the substance abuse that may also lead to the, as we know, the mind and the body are the two sides of the same coin. If the mind has been affected, the body automatically, if the body, this is a vice versa. Next, please. Actually, what is the treatment plan? How to approach the patient if a patient present towards you? How to assess and how to approach? When you go back, please. Okay, the assessment of a patient is not only done by the psychiatrist or by the psychologist. This is a teamwork. And if a patient present in our OPDs or in our settings, so we jointly decided whether the patient is suitable for the therapy or only for the modificational changes, or he is suitable candidate for the medication or the combination of the both. As we know that every patient is different from person to person, and the physician's opinion is also different for the same person. So this is a joint decision that is not only by the psychiatrist. We should also involve the paramedics, general practitioner. Initially, most of the person present toward the general practitioner, and the GPs will decide whether the patient should go towards the psychologist. As in the mild cases, there is no treatment of the medication. There's no need of the medication. In the mild depressive, like we should advise the patient to consult with a psychologist and dietary measures as well as the active monitoring. Next, please. Next. In most of the setting, they have to use the stepped care approach. In our setting, we also follow this approach, means the right care at the right time by the right person for the right duration. The mental health approach by a stepped care is divided into the four elements. One is the stratification of the population, the need groups, setting intervention for the each group. We have to use the comprehensive evidence-based medicine and target the treatment for each need group. So this is a step care approach. Next, please. So look at this. These are the step care approach of a 5 general group with the 3 different types. We should focus on the population at risk group, mild mental illnesses, moderate mental illness, and the severe mental illness. As we have discussed, there is no need of a medication in the mild cases. And if we talk about the 3 elements of a step care approach, is what do we need to achieve, what services are relevant clinically as well as for the suitable for the patient. And the third element is the what are the typical workforce required. So there is a difference for each group. So if, for example, the patient is in the population, we should only aware regarding the mental illness and the self-help resources. And there's no workforce required in the population. So sometimes we have need the self-help resources. While if we talk about the moderate or the mild, in the mild, they have a need of a workforce. So this is mostly not the learned, but the psychologists as well as appropriately trained and the qualified health professional we have to be. But if we are talking about the severe mental illnesses, like if a patient present in our setting with a suicide or the homicide, our first step we have to admit with the patient to save the life of the patient. Uh, yes. So, as we know, this is a multidisciplinary team. So, if a patient present with a psychiatric disorder and a comorbid physical illness, so we should also involve the physicians as well, and surgeon, teacher, as well as the parents may also play a big role for the management of the patient. Next, please. So if you or someone you know have a symptom of a mental illness, we should take action because of the stigma. Most of the person, most of the students are avoid to consult with a psychologist as well as psychiatrist. So in our setting, if a patient present in our OPD, so we should first assess the patient, then examination, and if possible we should ask for the investigation, and then we have joint make decision for the proper management of the patient. And the proper management, early treatment may improve the quality of life of the patients. Thank you.
Thank you very much, Dr. Moti Ram. It was a very enlightening session, and we have learned about some of the techniques and some of the steps actually. Yes, please.
Yes. One thing I want to discuss, most of the people think that the antidepressant or the antipsychotic drugs lead to the addiction, but
Yeah.
this is not true. Actually, the benzodiazepines drugs like the Xanax, alprazolam, Lexotanil, lorazepam, bromazepam, these are the drugs that may lead to the dependence, but with the antidepressant and the antipsychotics, may lead to the discontinuation symptom, but not the, so antidepressants are not the habit forming drugs. Thank you.
Very true. There is a lot of misperceptions regarding these antidepressants, and I'm sure there was a lot of learning lessons after the talk. Thank you very much to all the respected esteemed experts from the panel 2, panel 1, for sharing your thoughts. We have a lot of, again, chatting and dialogue going on in the chat and comment box. And thank you to Nadia and other experts. They are responding to the queries as well. Now we move on to the next session. We have kept it only for the students, and it's going to be led by our students. Actually, the significance of including students' perspective in this talk is to hear from them what kind of services they think are needed in terms of mental health, and what support services are available, to what extent they are satisfied with them. Now, I'm going to hand over to Ms. Mariam Akram. She's faculty member, visiting faculty, Department of Behavioral Sciences, to kindly moderate this session. And our students are going to present you with what they think about mental health. And I would request the students to kindly reflect on all of the presentations that you have heard today. Thank you.
Thank you so much, Dr. Sashta, for inviting me over here. First of all, I would like to thank all the speakers for such a wonderful and insight presentation about mental health. So many of the students have joined us. I would like to ask many fellow students for their comments on their understanding about mental health. All the students are ready, hopefully. So please raise your hand when I ask the question. What kind of mental health issues exist in your community? You have to address your community from where you belong. Okay, Aliza, please unmute your mic.
I'm Aliza. I would request the presenters to, if it is a possibility, to turn on your video if you are comfortable.
Sorry,
Okay.
ma'am, webcam is not working.
That's totally all right.
I'm Aliza Swail. I am from Fatima Women University, Rawalpindi. So I'm going to answer your question, Ms. Mariam. The main mental health issues in our community are already addressed by Dr. Nadia and Dr. Noreen. They've already mentioned most of the issues. But I will just add some little bit more that stigma in our society is a significant barrier to when we are addressing mental health issues. There's a general lack of understanding and acceptance of mental health problems, which mostly leads to discrimination and isolation for those who want to seek help. Many people who are their fear of being labeled as crazy or weak if they admit to having a mental health condition, which prevents them from seeking support. It's a very major issue in our society. Then also that Dr. Noreen has also already mentioned about the culture and religious beliefs that we have in Pakistan, which also influence how mental health issues are perceived and addressed. So I guess by promoting accessible and quality mental health services, we can reduce the stigma and educate the public in the country, and we can take a significant step towards supporting individuals in mental health community. So I guess that's the thing.
So in your community, like Pakistan?
Yes, specifically for Pakistan.
Okay,
the stigma and the religious beliefs and culture beliefs, which are mostly dominant in the Eastern society and
Thank you
Pakistan.
very much, Alize. Thank you very much, Alize. And I would request rest of the presenters to kindly do give us a reflection of the talk from the presenters today. What you have learned, at least one thing probably that is a takeaway message. Mariam, over to you.
Okay, ma'am. Thank you so much. Now I would like to invite our student Lishba from Fatima Jinnah University to address this question. What kind of mental issues do students with special need face, and why do they face these issues? Additionally, what can be done to help them cope with these challenges? Alishba, are you there?
Yes, ma'am, I'm there. Am I audible?
Okay, yes, you are audible. Thank you so much.
Okay, so thank you very much, everyone, for letting me here on this webinar. So talking about what kind of issues do special persons face? So yes, it is a truth that the special persons, they are 5 times more on risk than the normal people to face mental health issues, because they are one of the marginalized communities of Pakistan, and they face a lot of issues related to mental health. And why they face these issues, let me give you an overview.
First thing that happens in Pakistan is that the stigma that is attached with the special persons, that she is disabled or he is blind, so he cannot study or she cannot study, so give him or her a plate and let him or her beg on the street. So people think that the special persons or the people who are with special needs are not capable of studying or not capable of doing anything else. So, and if the special persons say that we want to study, then they are isolated. They are sent to the institutes where special persons are studying. So I think it creates I think the special persons, they create a whole world of themselves where only special persons exist. And then as a result, when special persons, they complete their education and they come to the practical life or they interact with the society, and the first issue that they face is the inferiority complex. They feel that we are inferior. Other people, they are with sight, or they can walk, they can talk properly, and we are inferior to them. And this, I think, this results in lack of confidence, and this also damages their personality badly. So I think what can be done to address this issue or to solve this issue is to make the special persons a part of our society. And when I'm saying that make the special person a part of our society, it means that treat the special person or treat the person who is with special needs with uh, like you treat your own friends, like you treat the persons who are your friends, who are not special, who are like ordinary people or who are normal people. Treat a special person like that, and you will see that a special person or a student with special needs is no different than others, and he or she can enjoy as much as you can enjoy. So I think first thing that can be done to solve this issue is this. Uh, then one thing that we can do is to accept that, okay, this person is special. So yeah, sometimes we have to cooperate with them. So yeah, the other thing that I would love to add in here is cooperation. Please do cooperate, but please keep in view that you should be cooperative, and you should not pass on remarks on the appearance or on the special needs, because I know special persons, they are quite touchy about that. And another thing that I want to address in here is people feel pity about special persons. People pity them. And I think we should not be pitying the special persons. We are not a pitiful character. We are just a part of the society, and treat us like the way that you treat your own friends. So, yeah, the special person, they face mental issues when they are not treated well. Like they face heavy anxiety, they face sleeplessness, they face depression, they face eating disorders. Sometimes special persons, they face eating disorders. There's a huge tendency of special persons who are facing PTSDs. The special persons, they are also facing hypertension, sleeplessness. There are a number of issues which are unaddressed, and the most common ones are anxiety, inferiority complex, lack of confidence, and sleeplessness. These issues, these are very common in special persons, and I know a lot of special persons who are into these issues and they don't know what to do with that. So I
Okay,
think
thank
what can be done is
yes.
to address these issues now. Some of the stories of Fatima Jinnah, they are coming to my mind. Like Fatima Jinnah, it is a good university, and the reason that I chose Fatma Jinnah is that I knew that there is no ableism, there is no stigmatization in that. And one incident that I would love to share is of Zara. She's my classmate. And once I was just walking through the corridor, so I heard Zara talking to someone, and a person was saying to Zara that, do you pity these special persons? So Zara said that, no, I don't pity them. And they are a part of our community. If they are studying with us, if they are competing with us, so we don't have to pity them, but in fact they are a part of our society and they are no different than us. So I was so happy and I was so excited to hear that yes, we are coming to a change. We are coming to a change, and the things are changing. So I would highly appreciate the efforts of Fatma Jinnah. In fact, Fatma Jinnah has established a counseling and wellness center, and every
Thank you so
person,
much. Yes, very true, Lishba, that Fatma Jinnah is really working hard to create an awareness and insight sessions for the special students and for the other students, so um, they can understand what is mental health and they can apply different kind of methods in their life. So thank you so much, Alishba, for such a wonderful reflection of the session. Now I would like to ask another questions, that what are the key signs and symptoms that you observe among your classmates, university, peer, and in your family? So anyone would like to answer or reflect from the session, what you actually gained it? Okay, Aisha Malik, yes.
Assalamu alaikum everyone. Hope you all must be doing great. First of all, I would like to thank you, Dr. Sajda, for giving me such a platform to join all of you and express my opinion among the professional. I also like to give the reflection on the previous presentation, and those were obviously very incredible. The keynote I would like to take is from one of our presenter who said about the active listening, and I guess being heard is that state where you felt the most complete, and your mental health get really satisfied if you're getting heard properly or you're getting heard with full attention. So now coming upon the question, ma'am, you have asked. So I guess mm, nowadays the most popular topic is mental health, and especially among our youth, and mm, this is going very vast. But there are times that we truly ignore symptoms and signs that our friends are experiencing. We are now university students and maybe doing some part-time work, internships, and engaging in other activities. So there are some signs and symptoms which we actually overrule, which we see in daily routine, that that person might be facing some mental health issue, but we completely overrule it. So for me, I guess the behavior shifts, the changing in behavior is such an like we should keep an eye out for notable behavior shifts in our friends and in the students we see, because they get so much irritated even in their normal routine. Even they're performing so simple tasks, so they're getting so much irritated, they're getting so much restless, and even we ask to come and join to do anything, they're like, no man, we are not fond of doing this, or I'm not feeling it to do. So I guess that behavior shift is one of the most common symptoms and key sign that the person might be getting some issues. Then again, they go for the social withdrawals, losing interest in with the friends, like not going to the cafes to eat something, or not joining or participating in different things. I can say that this is one of the major sign we should like be aware if our friends or even our colleagues are facing it. Then again, if we are more personal and we are more friendly to them, we can ask them about their sleeping pattern, their appetite change, and why they're being so low in their energies, because we know that okay, those are the person who are performing so well, but from few days or few weeks they're not being themselves. So I guess we should I know sometimes people do not bother about it. Even we being the psychology students, we also say okay, it's their personal life, but sometimes it's more than just being in their personal life. We can help people with their mood swings and help them to overcome all the things. So I guess
Yes,
these are the little we should
true,
cater.
very true, Aisha Malik. Just like Nora Fahad said, that we need to understand our trauma and our emotions so we can cater them. So thank you so much for such a great reflection. So my another question is, what are the cultural and personal barriers that individual face when seeking help for mental health issues? Anyone would like to answer that? Okay, Hadia. Yes, you can unmute your mic.
And good
Walaikum
morning, everyone. First of all, I would like to say special thanks to all of the presenters. This session was really very informative, and It was very focused on mental health. So first of all, I would like to explain what a barrier is. A barrier is any hurdle or a factor that makes it difficult for a person to seek mental health advice or help. So I will be first be highlighting some of the cultural factors. First of all, the first cultural factor is the perception of wellness is different from culture to culture. It means that a person might feel hesitant to go to therapy because in their culture it is not that particular problem is not that bigger of a deal. For example, in Pakistan, if a woman get divorced or she gets divorced, it is a very huge deal. It's a very big factor. But in other countries, it might not be that bigger of a factor. So this cultural barrier can make it difficult for her to go and opt for help or therapy. The second cultural barrier, in my opinion, is unfair or fear of treatment. People might be hesitant to go to therapy because they think that they will be given unfair treatment because of their gender, race, socioeconomic status, and physical appearance, etc. And the third and most important barrier is even in the 21st century, it is still considered a therapy or seeking help is still considered as a taboo in most of Asian countries and Middle Eastern countries. People are scared to be called crazy or insane by their society, and even in the younger generation, for example, in Gen Z, people are constantly scared that they will be labeled as emo kids or mental by their friends and their peers. So these are the most important cultural barriers or hurdles that people face when they are trying to seek help or when they try to opt for therapy. Some personal factors or barriers that come are first of all, label avoidance. A person can be hesitant to go to therapy because they might get labeled as autistic, ADD person, a schizophrenic, etc. People are afraid of being labeled as a particular disorder. So that's that. And they might another personal barrier is that they might see is going to therapy and asking for help, they might see as a sign of weakness. Person think that if they seek help, it means that they're too weak to sort their problems out by themselves. And in this particular point, it is pointed towards the men because they think that they're too strong to go for therapy and their emotions don't matter that much.
True, very true, Hadia. Just like Dr. Nadia Ibrahim said that parental and peer pressure is very
Yes,
judgmental for the students, and they mostly are family members and friends do not allow us to show our emotions. If we are overwhelmed or burn out, they say just take it easy or ignore it. So these are the things, right? Thank you so much, Hadia, for such a great reflection. Thank you so much. Okay, my next question is, what is the role of student support service in your university in improving mental health? Please address your university and reflect with the presenters what they are doing in your university as helping out. Who wants to answer? Okay, I think so, Zara.
Yes, ma'am. I'm Zara from Behavioral Sciences. Thank you, first of all, to Dr. Sajda, Dr. Iram, Ma'am Mariam, for giving me this opportunity to come on this platform, listen to all of the informative lectures, you can say, the speakers had. And I want to agree with Aisha that my almost favorite point was about the active listening thing, that we just need to lend an ear to someone, right? And half of their problem is gone from there. And then the second favorite point that I had throughout this session was that the one that sir made, that the right person at the right time and the right duration, and that one, because it's definitely important that, okay, we're listening to someone, that's the least a common person can do, right, who doesn't have any professional training. But for the specialized services, there has to be the right person to deliver those special services, the professional help, what we call it. So coming to your question, I think universities and campuses and the university life undeniably is very significant for a student throughout their educational journey. From my personal experience and from the experience of my class fellows, I can say that a lot of grooming definitely takes place on campuses. And so for that, catering to their mental health and their emotional well-being is also very important, that Fatima Jinnah Women University, I can proudly say that has catered to. We have different centers that help us if we need any help. That is the Counseling and Wellness Center, that is which was created by Dr. Iram, our chairperson as well of behavioral sciences, and she is the director of Counseling and Wellbeing Center. It is fully functional and it is offering services not only to the behavioral sciences student, but it is offering service throughout the university. And I myself have witnessed and heard students talking that we are availing the services and they're benefiting from it. And along with that, we have the Suicide Prevention Center that was inaugurated by Dr. Leela Maqsood, which is also commendable, that suicide is also a very less talked about topic, and her creating that center has really put that on the front for the students to
Yes,
understand that yes,
true, very true. As Dr. Iram already mentioned, that we are providing most of the internees are provided, graduated internees are providing selflessly interventions on mindfulness, acceptance-based therapies, and CBT. So thank you so much for your reflection. And I also work at Fatima Jinnah University, where we celebrate, and this was initiated by Dr. Iram Gul, the virtues. We celebrate every month a virtue, that is gratitude, integrity, happiness, different kind of. So the students can basically provide the service to the other students and know how they can improve their mental health. Thank you so much. Now I would like to play a video of the Counseling and Wellness Center at Fatima Jinnah. So here is the video. Can I share this?
Yes, I think you can share your presentation to the larger audience. And thank you very much to
Okay.
all of the students. I think it was commendable talking about your experiences. I think it is going to be a 3-minute video, 3 to 3.5, and we'll move to wrapping up of today's session by taking a couple of questions towards the end.
Okay.
I think there might be feeble voice behind it, but we don't need to have any, there's no background voice behind it. It's just the music. So we just have to probably look at it. And this is the vision and mission of our counseling center. That is where the counseling center is located.
Thank you so much, everyone, for joining us and watching the video. And thank you so much, Dr. Sajda, for providing this platform and joining us together internationally. So over to you.
Thank you very much, Mariam. This entire session was basically led by the students. They have themselves organized it, and they really were excited about sharing their views and participating. And we are now moving towards the end of this prolonged webinar. I very much thank your patience and in terms of listening. Before I wrap up, I think I would like to just acknowledge that there have been a number of queries that has been shared by our participants from different countries, and all of you have shared how similar the circumstances and sometimes the presentation of events or symptoms could be in different cultures. All of the presentation contents definitely would be shared with you later on as well. But again, I like to thank all of you. Towards the end, I would like to ask any of the panelists if you would be interested in kind of responding to any of the queries here, or giving us a brief comment on how you found this webinar as, and then we'll request Dr. Irumgul to kind of wrap up this session. You're most welcome. You're most welcome, Gurpreet Rana, and other people who have joined us from other countries. We will be floating your questions to our respective speakers, and hopefully they'll get back to you with their suggestions. Dr. Irumgul, as we don't have more to say, we would like you to kind of give us any concluding remarks at the end of the session today. Thank you so much.
Thank you, Dr. Sajda. Thank you very much. First of all, I would like to thank the Global Consortium of University for giving us this platform to conduct the webinar, and obviously the HASA team as well. So thank you all the resource person for joining us today at this enlightening seminar on mental health, a universal human right. We had the privilege of hearing from our distinguished resource person who has provided us with valuable insight into the significance of mental health as a fundamental human right. I would like to extend my heartfelt gratitude to our esteemed resource persons for their thought-provoking and informative presentation. The importance of mental health cannot be overstated, and it's not only a medical or psychological concern, it's a basic human right that should be accessible to every individual, regardless of their background, social status, or geographical location. Today, our presenters have shed light on this fundamental aspect of human well-being, offering us a deeper understanding of the challenges people face in different parts of the world and steps we can take to support mental health as a universal human right. I would like to thank our organizing committee and all the participants, our students, and other individuals who have made this seminar a success. It is through collaboration and shared commitment to promoting mental health as a universal human right that we can make a positive difference in the world. Wonderful job, Dr. Saida. I think you were able to organize this seminar in a very good manner, and all your team should be appreciated. So in conclusion, I would say that let us remember the journey towards recognizing mental health as a universal human right is ongoing, and it requires our collective efforts. Let us take the knowledge and inspiration gained from today's seminar and turn it into action, making a world a better place for all. I would also like to thank Mariam Akram and all the students for their, the way they shared their thoughts and the way they shared their ideas. And together, I think we can make a significant difference in the life of the countless individuals who deserve access to mental health and support they need. So thank you. Thank you, everyone. Have a wonderful day.
Thank you very much, Dr. Iram, for your beautiful words. And obviously, at Fatima Jinnah, we do a teamwork and we have a lot of learnings from each other. Towards the end, I would like to thank esteemed panels, the team from CUGH, Jinnah and other colleagues, Najar, Dalal. Thank you very much for organizing this webinar. We are all, approximately on time, and we would like to formally close this session with a vote of thanks to everybody that has contributed. Hopefully, we'll see more brighter days in coming time. Thank you very much for joining. Take care. Bye bye.
Thank you so much. Bye bye.
Thank you.
Take care.